this video, we will see how NST is done. NST is non-stress test. Non-stress test is the most common screening for antepartum evaluation of fetal well-being. So, with the NST machine, we can do NST, that is non-stress test, which is done in antepartum period, or we can do CTG. CTG is same. CTG and NST are same. Difference is that non-stress test is used in antepartum period and CTG cardiotocography is used in intrapartum period. NST, when the patient is pregnant but not in labor, we can monitor only FHR of baby. So NST is graphical evaluation of FHR in antenatal period. So we can see only single graph. So this is the graph of NST, only one graph, which is of fetal heart rate. And in CTG, as the name suggests, it is cardiotocography. Cardio matlab FHR and toco means uterine contraction. So we can have two graphs, one for cardio, that is FHR, and next is toco, that is uterine contraction. So such a graph is CTG. Now we will see NST karte kisme hai. NST is routinely done in all the high risk pregnancy like diabetes, hypertension, kidney disease, history of fetal death, and also in the patient who complain of decreased fetal movement. NST is done usually after 32 week, but in some cases it may be done before 32 week also. So what are the basic characteristics we see in the NST? So first, there is something called baseline heart rate or basal FHR. The basal FHR is 110 to 160. If the rate is less than 110, we call it bradycardia. Bradycardia is maybe due to head compression, maybe due to fetal distress, maybe due to heart block. And if the rate is more than 160, we call it tachycardia. Tachycardia may be due to maternal fever, cardiac arrhythmia, or some drugs like atropine or terbutaline, or it may be indicator of fetal distress. So both may be indicator of fetal distress. And also there is something called beat to beat variability. A baseline variability of 5 to 25 is a sign of fetal well-being. If the beat to beat variability is between 5 to 25, it is normal and the baby is healthy. Beat to beat variability is actually the fluctuation of FHR with the amplitude. Like this is plain, clean, so this is not normal. So this is unhealthy baby. If there is zigzag pattern, zigzag, 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 so this is a normal FHR pattern. So this is beat to beat variability, and this variability should be within 5 to 25 beats per minute. And loss of beat to beat variability is the early sign of fetal hypoxia. Loss of beat to beat variability may also be due to some other conditions, like if the baby is sleeping, if the baby is compromised, if the fetus has acidemia, if there is a history of drug in mother like Maxulf, analgesics, etc. Now we will see what acceleration and deceleration means. Acceleration means there is increase in heart rate by 15 beats per minute for at least 15 seconds. So if we are doing NST after 32 week, then this definition fits, like increase in FHR by 15 beats per minute for at least 15 seconds. But if we are doing NST before 32 week, this definition is changed as increase in FHR by 10 beats per minute for at least 10 seconds. And what deceleration means? Deceleration means decrease in heart rate by 15 beats per minute for at least 15 seconds. So if the patient complains of decreased fetal movement, we will proceed by doing modified biophysical profile or NST. If any parameter of them comes abnormal, we will do the entire biophysical profile. Now let's see. If we do NST, we observe the patient for 20 minutes. If there are 2 or more than 2 acceleration, we say the baby is reactive or healthy or reassuring, and we will follow up the baby weekly. A reactive NST means that fetus is not in danger for at least 1 week. If the acceleration are less than 2, we observe for 20 more minutes, and now if the acceleration comes more than 2, this is reassuring, reactive, and the baby is healthy. If it is still less than 2 acceleration in the observation, we say the baby is non-reassuring, the baby is non-reactive, and now we will proceed by doing BPP. If there is persistent late deceleration or persistent variable deceleration, we will promptly deliver the baby. NST is done by putting the patient in left lateral position, and we will observe for 20 minutes. And if there are 2 acceleration in 20 minutes, we will observe for 20 more minutes. So this is the CTG machine, cardiotocography machine. It has 2 bands, one for cardio and one for toco. Now we will see what early deceleration, what late deceleration, and what variable deceleration means. Early deceleration. So this is the graph showing early deceleration. In this graph, we can see the first one is FHR. There is a dip in FHR, and there is uterine contraction. So we will see the dip in FHR is corresponding with uterine contraction. The onset of dip in FHR is corresponding with onset of uterine contraction. The end of FHR, dip in FHR, corresponding with end of uterine contraction. So this is early deceleration, and we can see the dip is gradual. It took more than 30 seconds to come to peak. So the dip is gradual. So this is early deceleration. Early deceleration is physiological. It may be due to head compression, and in this case we manage only by follow-up. We just wait and watch. In this graph we can see late deceleration. This is the graph of FHR, and this is graph of uterine contraction. We can see the dip in FHR comes later than the uterine contraction. First there is uterine contraction, and then after uterine contraction there is FHR. That means C comes, then D comes. That is, first we can see contraction, and then we can see dip. So if we see such a graph, that is D after C, first contraction, then dip. C for contraction and D for dip. So if we see such graph, we can see this is late deceleration. Also the dip is gradual, that is it takes more than 30 seconds to come to peak. Such a graph comes in uteroplacental insufficiency, and this is the most ominous graph. This is the worst graph, and in this case we manage by putting the patient in left lateral position, connecting IV fluid, connecting oxygen to the patient, and if there is uterotonic tug, we stop the uterotonic tug, and if still, and we will repeat the CTG, and still if persistent late deceleration, we will deliver the baby, and mostly LSCS is done. So this is late deceleration. This is the graph showing variable deceleration. This is FHR, and this is uterine contraction. The dip in FHR, the contraction and the uterine contraction, there is no relationship at all, corresponding or not corresponding. It is varying in the whole graph. So there is no relationship between FHR pattern and the uterine contraction, and also there is sudden dip. So this is variable deceleration. Such a graph is seen in cord compression. So how will you manage if you see variable deceleration in CTG? So we can manage the patient by putting the patient in head low position. Putting the patient in head low position decreases the probability of cord compression, if any, and we will check for cord prolapse by doing PV, and also we will connect IV fluids. If still the cord compression persists, if still the variable deceleration persists, we can say it is persistent variable deceleration, and we will do the prompt delivery by cesarean. If the NST comes abnormal, or if there is very high risk pregnancy, we will do Manning score or PPP. Biophysical profile is a method using 5 biophysical variables to assess the status of fetal well-being antenatally. The 5 variables together are called biophysical profile, and we score 2 for each: 2 for breathing, 2 for amniotic fluid volume, 2 for tone, 2 for movement, and 2 for NST also. So total is 5 variable and 2 score for each, so it comes 10. So the components are Batman, B for breathing, A for amniotic fluid volume, T for tone, M for fetal gross body movement, and N for NST. So let's and also we will remember all these variables as 1, 2, 3. So there should be at least one breathing. So the first component is breathing. Breathing is the first to be affected by hypoxia. At least one episode of breathing lasting for 30 seconds, we will give score 2. At least one breathing, 1, and 2 for amniotic fluid volume. We see single vertical pocket more than 2 cm, so we will give score 2. We see tone, fetal tone. Fetal tone is assessed by an episode of complete extension followed by complete flexion within 30 minutes of observation. So complete extension followed by complete flexion is the good tone. So we give it 2 marks, 2 scores. and we will see fetal body movement more than 3 cross body movement, we give score of 2, and if the NST is reassuring or reactive, we give score 2. So total the score is 10. If the score is 8 to 10, we say it normal and we will follow up. If the score is 6, we repeat. After 12 to 24 hours, we evaluate and deliver. If the baby is fetus is less than 36 weeks, we monitor till the term and we deliver accordingly. And if the baby is more than 36 weeks, we deliver the baby. If the score comes less than 6, we deliver the baby irrespective of gestational age. But it is very time taking, like going through all these parameters: breathing, amniotic fluid volume, tone, movement, NST. It is very tedious and time taking. So there comes modified BPP. Modified BPP, we see only 2 parameters like NST and AFI. NST signifies acute hypoxia and AFI signifies chronic hypoxia. So this is all about biophysical scoring. Now let's revise what we learnt already. So this is the actual CTG. The first graph is showing FHR and the second graph is showing uterine contraction, and we will see whether it is early, late or variable dissolution. We see the onset of peak is corresponding with the onset of uterine contraction. The height of peak is corresponding to the height of uterine contraction, and the end of peak is corresponding to the end of uterine contraction. So this is early deceleration, that is the fetal graph is corresponding to uterine contraction. Now in the second graph also, in the second wave also, we can see the height of FHR is coinciding with height of uterine contraction. Again the height of FHR is coinciding with height of uterine contraction. So it is very easy. We can say this is the early deceleration. Early deceleration comes in head compression. It is not associated with fetal hypoxia. It is physiological. We will just wait and watch. In this graph, in this actual CTG, we see this is showing uterine contraction. This is showing FHR, and now we will discuss. So this is FHR, this is uterine contraction. Now we will see this is uterine contraction C, onset of C. So first there is onset of C, then there is onset of D, that is then there is onset of FHR dip. FHR dip is after the onset of contraction. Onset of FHR dip is after the onset of contraction, that is there is C after D. So this is late deceleration. This is the worst deceleration and it indicates uteroplacental insufficiency. Okay, this is easy. And this is the graph showing variable deceleration. See, the peak is not coinciding. So there is no uniform, there is no relationship between FHR and the uterine contraction. This is a zigzag pattern and the tip is very sharp. So this is variable deceleration. Variable deceleration means cord compression.